Good evening, folks, ladies and gentlemen, esteemed doctors, Dr. Manvi Gupta and Govind. Uh, Very warm and hearty welcome to our Thursday evening webinar on wellness, vitamins D and B12. Vitamins D and B12 have long been associated with a lot of ailments. The deficiency of vitamin D and B12 has long been associated with a lot of ailments. They play a crucial role in maintaining overall health and functioning of the body. Their importance can be understood by looking at the specific roles that they play and the consequences of their deficiencies. We have with us today Dr. Manvi Gupta, and I think she's experiencing a little technical difficulty here. But as soon as she's back, we'll start the webinar, and she will take us through a experience of kind of ailments, diagnosis, and the road to recovery with the vitamins B and B12. Dr. Gupta, over to you, ma'am.
Yeah. Good evening, everybody. So I am Dr. Manvi Gupta. I am consultant pathologist at MG Bath Lab. So today I'll be covering vitamins D and B12, the associated ailments, diagnosis, and the road to recovery. So let's move on to the next slide. Next slide. So as we all know that vitamins comes from the Latin words, which means vita, which means life. And these are the organic components in food, which are needed in very small amounts, but they are really very, very important for growth and maintaining a good health. And we must eat a certain amount of vitamins to stay healthy. And these are found in very small amounts in many different kinds of foods. So next slide. So based on their solubility, vitamins are mainly of two types, the fat soluble and the water soluble vitamins. So the fat soluble vitamins, as we all know, can be stored in the body for a longer time as they're soluble in fat. And these include vitamins A, D, E, and K, while the water soluble vitamins are vitamin B and C. So since they are moving with the water component, so they can be excreted out in the kidney. Next slide. So this slide explains that the water-soluble vitamins are vitamin B complex and vitamin C. So being water-soluble, they can be easily flushed out by the kidneys from our body. Next one. So coming on to the main topic, I'll be covering it under various headings, which include the introduction, structure, functions, sources, the causes of deficiency, and how to diagnose and treat them. So next slide. So coming on to vitamin D. Next slide. Vitamin D, as we know, is known by different names, but the most important one is the sunshine vitamin. Apart from them, we also call it as the anti-rachitic factor, calciferol, or cholecalciferol. Next. So it's a fat-soluble vitamin, and it is synthesized in the body, most importantly, when we are exposed to sunlight. So around 1 billion people worldwide have a vitamin D deficiency or insufficiency. Next. So these days, it's a new consideration that vitamin D has been included as a hormone. So as it can be synthesized in the body, it is released within the circulation and has distinct target organs. And the action is almost similar to a steroid hormone. Next one. So there are two forms or true provitamins of vitamin D, the ergosterol, which is the basic building block of vitamin D in plants, and the 7-dehydrocholesterol, which is the basic building block of vitamin D in humans. So ergosterol is also called as provitamin D2, and the human form is known as provitamin D3. Next. So once the slide here depicts that once the body is exposed to the UVB light in the sun rays, so the provitamin D3 is converted into vitamin D3, which is cholecalciferol in humans, and in the plant food, it is converted into vitamin D2. This further binds to the D binding protein in the circulation, and then it is taken up to the liver, where it is converted into the first hydroxy, that is the 25-hydroxy cholecalciferol, and later on it is taken into the kidney, where it is converted into the 125-dihydroxy cholecalciferol, which is also the active form known as calcitriol. Next. So the active form of vitamin D is 125-dihydroxy cholecalciferol, also known as calcitriol. Next. So the slide here explains the functions of vitamin D. The main function is to maintain a normal plasma level of calcium and phosphorus. Well, this it does by having its action on the intestine, bones, and kidneys. So in the intestine, it basically increases the absorption of calcium and phosphorus, and in the kidney, it does the same, and it also decreases the excretion. Whereas in case of bone, it increases the resorption of bone so that more and more of calcium is mobilized from the bones. Next. So whenever there is a low plasma calcium level, the parathyroid hormone level increases, which leads to an increased level of calcitriol. So the calcitriol acts on the bones and mobilizes calcium from the bones, and it increases the absorption of calcium in intestine and in the kidney, and it decreases the excretion. Thus, it leads to a maintained plasma calcium level. Next. Apart from that, vitamin D improves heart function, it enhances brain development, it strengthens the immune system. It's very essential for strong bones and teeth, a muscular function, and it also provides anti-cancer effects. Next. So, vitamin D is a miracle hormone, we can say. It is anti-aging, cancer, anti-diabetic, anti-infective, antidepressant, anti-hypertensive, and it's cardioprotective as well. Next. So the main source, as we know, is the vitamin D sun exposure. Apart from that, we can avail it from food sources like cheese, margarine, butter, fortified milk, healthy cereals, and fatty fish. Next. Next slide. Okay, so the slide here depicts the recommended daily allowance, which is around 400 international units for children up to 1 year, and from 1 to 70 years, it's 600, and above that, it's 800 IU. Next. So coming on to the causes of deficiency of vitamin D. Next slide. So the first, next slide. So the first and foremost is whenever there is an inadequate exposure to sunlight, which could be in case of the individuals who are limited exposure to sunlight, as they are working within their houses, or they are wearing too covered clothes. And the second reason could be decreased synthesis within the skin. This mostly occurs in people with a darker skin, and in case of excessive application of the sunscreen. So that leads to limited exposure to the sun rays, which could lead to vitamin D decreased synthesis in the skin. Next. So a decreased synthesis in the body could be a result of health conditions which might be involving the parathyroid glands, kidney. It also occurs in aging or in genetic susceptibility. Next. So inadequate dietary intake, mostly vegetarians, people following a strictly vegetarian diet, which is devoid of eggs, fish, and meat. So since these are good dietary sources of vitamin D, so they tend to have vitamin D deficiency. So even in people with malabsorption states in which the absorption of vitamin D is not good, so in the like Crohn's diseases, celiac diseases, so vitamin D deficiency definitely occurs. And in case of breastfeeding, if the mother is vitamin D deficit, so the kid is definitely bound to have a vitamin D deficiency. Next. Another risk factor is obesity. So the fat cells, they extract vitamin D from the blood and affect its release into the circulation. So obesity is again another risk factor for vitamin D deficiency. Next. So deficiency of vitamin D, it presents as rickets in children and it's known as osteomalacia in adults. So we'll be seeing and discovering the features of both. Next slide. So rickets, again, we see a decreased serum calcium in the blood along with soft and pliable bones. We can see bone deformities, delayed dentition, and delayed closure of anterior fontanella. Next slide. Similarly, osteomalacia, which is known as adult rickets, it again presents with decreased serum calcium. So the bones are soft and pliable, and they are very prone to bone deformities and easily fractured. Next. So apart from that, the vitamin D deficiency also presents with features like sleep changes, fatigue, there are frequent infections, coughs and colds. The muscle strength is reduced and there may be weak and aching bones, loss of appetite. Even in cases like there may be there may be a lot of hair fall and bad skin days. Next. So now diagnosing vitamin D deficiency, we have three main categories: the clinical features, the rheological picture, and the biochemical findings. Next. So coming on to diagnosing rickets. So the earliest bony lesion that occurs in children is craniotabes, in which we find small unossified areas in the membranous bone in the skull. So in case we apply pressure, there is inward buckling of the parietal bone. So this is craniotabes. This is the earliest sign to be featuring in kids. Next. So apart from that, we can see frontal bossing, and there is a delayed closure of the anterior fontanella. Next. And in these slides, there are other features. We can see bowed legs, which is known as genu-varum. Then there are costochondral swellings. That is the costochondral junctions. They show small swellings, which is known as rachitic rosary. Apart from that, they can be knock knees. That is, these are joint knees. And then there is Harrison's sulcus below the rib cage, and there is Pott's belly. Next. Some of the cases, we can see changes in the spinal cord, which infest as kyphosis, lordosis, or even scoliosis. Next. So again, this slide features it combines all the features in the kids, as we can see. Next. So in adults, osteomalacia, there are bone pains, muscle weaknesses, there is a waddling gait, and there's a lot of tendency of easy fractures. Next. So rheologically, what we can find is, next, there is a widening and irregularity of the growth plate, which is known as fraying. And along with that, we can also see a concavity of the metaphysis, which is known as cupping. And the metaphyseal end may be widened and in some cases, which is known as playing. Next. So the decreased bone density, it may be seen as characteristic erased or fuzzy type of demineralization. There is a coarse trabecular pattern, or there could be a loss of cortical definition. The cortex reveals it to be thinner and altered in structure. Next. So we can also see the loser zones or pseudofractures. Linear radiolucencies can be seen occurring bilaterally and symmetrically. Next. So again, this slide shows there is an increased tendency of fractures, and even in the vertebra, we can see codfish vertebra. Next. Lab investigations. Next. So in the lab investigations, the first and foremost is the testing of serum vitamin D levels. So we have various modalities in this regard. We have the ELISA, we have the radioimmunoassays, the fluorescent immunoassays, and the chemiluminescence assays. Next. So the slide here, it compares the various testing modalities. So starting from ELISA, going on to the highest, that is the CLIA. So as we all can see that the detection range of CLIA is really high with a good sensitivity and specificity. And the time consumed is very less. But yes, the main advantage of ELISA over CLIA is that the cost of the machine is less and the testing cost is less. So depending upon the type of infrastructure we have, we can get the vitamin D levels tested. So depending whether we have the CLIA kind of machinery, or we can step up only to the basic ELISA kind of machinery. So, but still the test results are good with both. Next. So the slide here depicts the normal level for vitamin D are more than 30 nanogram per ml. So below 30 is a insufficiency, and below 20 we can say it's deficiency. And toxicity can also occur in certain cases, which is more than 150 nanogram per ml. Next. So the other biochemical findings we can be finding in correlation are low serum calcium and phosphorus, increased serum alkaline phosphatase, increased PTH, and low urine calcium levels. Next. So coming on to the treatment and prevention. So for the treatment, usually it's a 60,000 international unit once or twice weekly for 8 to 10 weeks. Or if anybody wants to go in for injectable, so it's a 6 lakh IU stat dose. And after that, there are maintenance doses, but repeat x-rays have to be done. And calcium supplementation is a must. Next. So for prevention, the first and foremost thing that we require is adequate sun exposure. So depending upon the type of place a person lives in and the type of climate, sun exposure, the timings and the timing of the day has to be decided. Like for people living in like if it's winter weather, so in those cases you require a longer exposure because the body is covered and lesser amount of exposure area is there. Whereas in summers, the body is less covered and the exposure area is larger. So depending on that, so the exposure time could be 5 minutes to 2 hours. Next. So apart from that, the pregnant and lactating mothers should take 400 international unit vitamin D supplements daily, and also fortification of foods with vitamin D such as milk, butter can be done. Next. So that was all about vitamin D. Now, as we can start with vitamin B12. Next. So vitamin D is also known as a cyanocobalamin, the anti-pernicious anemia factor or extrinsic factor of Castle. Next. So it is one of the 8 vitamin Bs, and it has a very complex structure. It's water soluble, and since it is rapidly degradable, so it has to be stored in a dark place. Next. There are 4 forms of vitamin B12, and the forms they are differentiated group. So these are the cyanocobalamin, hydroxy, methyl, and adenosylcobalamin. Next. So the first is cyanocobalamin with the cyanide group in the center. And next. And it is stable during processing and storage, so it can be used for food fortification, multivitamins, and B12 supplements. Next. The next is hydroxycobalamin with a hydroxy group. Next. IM treatment of vitamin B12 deficiency, and it is also an antidote for cyanide poisoning. Next. The methylcobalamin form has a methyl group. Next. So it's used in the treatment of neuropathies, peripheral or diabetic neuropathy, and in the preliminary treatment of amyotrophic lateral sclerosis. Next. Adenosylcobalamin is one of the biologically active forms of vitamin B12, and it is next. So the screen here shows the absorption of vitamin B12. So once the vitamin B12 is ingested, it is bound, which is released from the salivary gland. Now this heptocorrin, it takes it to the stomach, and as we know, in the stomach we have the parietal cells which secrete intrinsic factor along with the hydrochloric acid. So as this the heptocorrin B12 complex, it moves towards the duodenum, the pancreatic proteases, they release the heptocorrin from B12, and they help in binding of intrinsic factor to B12. So this B12 intrinsic factor complex, it later travels down to the ileum, and here the intrinsic factor is released and the B12 is absorbed, and later on it is taken up by transcobalamin to the liver. So around 50% of the B12 absorbed in the body is stored in the liver. Rest of it is delivered to the other organs in the body. So liver has a good store of vitamin B12. Next. So functions, coming on to the functions of vitamin B12. Next. So B12 is very important for DNA synthesis. It helps in the formation of blood mucous membranes. It is also required for energy metabolism, lipid metabolism. It also required for the functioning and formation of messenger substances and in detoxification. Next. So vitamin B12 has a major role in 2 main pathways in the body. One is the conversion of methyl malonyl-CoA to succinyl-CoA, and the other is conversion of homocysteine to methionine. Next. So the first cycle that vitamin B12 takes part is the catabolism of odd chain fatty acids and branch chain amino acids. So these are converted to propionyl CoA, and this is further with the help of B12, it is converted into methyl malonyl CoA. Now, next. So in case this conversion does not happen, there is an excess of methyl malonyl CoA. So this methyl malonyl CoA excessive accumulation in the body can lead to methylmalonemia, that is excessive accumulation in the blood. It can also be excreted in the urine, which is known as methylmalonic aciduria. And later on, this methylmalonic acid, that is the MMA, it leads to neuropathy. It leads to myelin. Next. So another conversion that B12 is required is for to methionine. This is a complex equation in which hormone and B12 is required in the process. And in this process, B12, it frees the N-methyl tetrahydrofolate to folate. This folate is further utilized in the conversion of deoxyuridine monophosphate to deoxythymidine monophosphate, which is later required for the functioning of and formation of DNA. So one disturbance, that is a vitamin B12 deficiency, it leads to excessive accumulation of homocysteine. There is a decreased release of folic acid, that is known as folate trap. And thirdly, there is a decreased formation of DNA. Next. So this slide again it shows the effects of vitamin B12 deficiency. So once there is a decreased methionine formation, it leads to decreased myelin formation and decreased neurotransmitter formation, which affects the brain function. So the increased homocysteine in the blood leads to brain damage and cognitive disturbances. Thirdly, the folate trap, that is the folic acid deficiency, and the decreased DNA synthesis, they lead to failure of nuclear maturation of the cells. So the proliferation of erythroblasts, these are the precursors of red blood cells. It fails and it leads to formation of big macrocytes, which are rapidly destroyed, which leads to further anemia, which is known as megaloblastic or the macrocytic anemia. Next. So relationship between vitamin B12 and folic acid deficiency is that vitamin B12 deficiency leads to demyelination and neurological disease with subacute combined degeneration of the spinal cord. And also vitamin B12 deficiency further leads to folic acid deficiency in the form of folate trap. So this leads to reduction in the DNA synthesis, which leads to formation of big macrocytes, which are fully hemoglobinized, that result from a decreased cell division during erythropoiesis and leads to megaloblastic anemia. And also there is inadequate DNA synthesis, which affects the rapidly growing tissues like tongue, which leads to glossitis and macroglossia. Next. So the sources of vitamin B12 include seafood like shellfish, fish, crabs. Next. Red meat, liver, beef. Next. So the slide here depicts the RDA for vitamin B12, which includes 0.4 microgram for infants and 2.4 micrograms in case of adults, and 2.8 micrograms in case of breastfeeding. Next. So the causes of deficiency of vitamin B12 again include a decreased intake, which occurs in case of alcoholic absorption because it reduces the B12 intake, and in case of vegetarian diets. Whereas a defective transport, which occurs in case of transcobalamin deficiency, malabsorption, which occurs either from food or lack of intrinsic factor, which can be occurring in case of pernicious anemia, gastric bypass, gastrectomy, or H. pylori infections, and other disease conditions like Crohn's disease, bacterial overgrowth, and ileal reaction. Next. So how to diagnose the B12 deficiency? Next. So the vitamin B12 deficiency. It has the dietary as well as the compromised absorption. It is affecting the red blood cells and the central nervous system. So the effects are mainly that can be seen are on the red blood cells, which is in the form of megaloblastic anemia, which can be detected on the peripheral blood films, bone marrows, as well as the clinical signs and symptoms in the form of central nervous systems. Next. So, people with anemia, we can find there is a shortness of breath, pale skin, there are palpitations, and then we have glossitis with the mouth ulcers. And even in certain cases, since megaloblastic anemia has some factor of hemolysis, so we can also find jaundice, and there's a disturbed vision. Next. So the neurological changes that we see is the peripheral nerves are usually affected first, and there are paresthesias, that is there is tingling and numbness, and there can be glove and stocking type of paresthesias. Next. So next, the posterior columns are impaired, and there is a problem with balancing. Cerebrum, once the cerebrum is affected, so there can be delusions, there could be illusions, cognitive impairment, dementia, and even in certain cases, there could be optic atrophy. Next. So these were the symptoms. Coming on to the laboratory findings. Next. So the first and the foremost investigation comes on to the hemogram. That is, the CBC shows us anemia, a low HB level, and the hemogram shows us MCV, which is very high, starting from 110 to going on to 140 femtoliter. And in certain cases, we can also find pancytopenia. That is all the three parameters. That is, the HB is low, the WBC count is low, as well as the platelets are low. Next. So the peripheral blood film shows us an anisopoikilocytosis in which we can find macrocytes. Along with that, we can also find macroovalocytes, target cells, teardrop cells. Nucleated RBCs are also very common, along with basophilic stippling, and the WBC series, they show hypersegmented neutrophils. Usually they are 5 lobes, but in these cases, they may have up to 6 or 7 lobes. Next. So the slide here shows the macrocytes and the macroovalocytes. Next. So there are macroovalocytes with a hypersegmented neutrophil and a teardrop cell. Next. The slide shows nucleated RBCs. That is, usually the RBCs, they don't have a nuclei, but in these cases, the nuclei are retained. Next. So here we can see punctate basophilia, that is small punctate basophilic dots within the RBCs. And basically, these are the ribosomal RNAs. Next. So one slide back, yeah, bone marrow. So again, in the bone marrow findings, we can see there is an erythroid hyperplasia, and which is because of the ineffective erythropoiesis. And there is a megaloblastoid change in the erythroid series. So there are the erythroid series has a large abnormally large cells and asynchronous maturation of nucleus and cytoplasm. That is, the cytoplasmic maturation, it continues. But since there is an impaired DNA formation, so the nuclear development lags behind. So in the myeloid series, we can see giant metamyelocytes, which are very characteristic. Next. So the slide here shows erythroid hyperplasia. That is, the myeloid erythroid ratio is reversed in these cases. Next. So this is a megaloblast in which we can say that it is the nuclear cytoplasmic ratio is altered. So there we can see the giant metamyelocytes in the myeloid series. Next. So in the biochemical findings, we have different tests to detect the B12 deficiency. The first is the B12 levels in the serum. Again, we have the previous modalities like ELISA, RIA, the fluorescent immunoassay, and the CLIA. So these, with the help of
I believe ma'am is having a little technical difficulty here. Please bear with us while she rejoins the webinar. Yes, ma'am. If you can you say something? Can't hear you anything. Dr. Gupta?
Hence, how we can test the serum vitamin B12 levels. So we have the various modalities like ELISA, the radioimmunoassay, fluorescence immunoassay, and the clear. So cases less than 200 picogram per ml are vitamin D deficit, and so more than 406 picogram per ml are unlikely to be deficit. So the borderline cases are 211 to 406, which need to be ruled out. Next. So the diagnostic accuracy of serum B12 levels is low, as as we don't have a gold standard, and the cutoff values are inconsistent. So different labs have different values, and the fraction of vitamin B12 bound to heptachlorine poses a problem. So the serum vitamin B12 levels are a poor indicator of bioavailable cobalamin. So total B12 levels. Apart from that, we have other different tests in which we can through which we can get an estimate whether the patient is vitamin B12 deficit or not. These are portrayed in the coming slides. Next. So we can go in for the MMA testing or the homocysteine levels in the serum. So the serum methyl malonic acid and serum homocysteine are more sensitive for detection of vitamin B12 deficiency rather than estimation of vitamin B12 levels, because these are raised in early tissue deficiency even before the appearance of hematological changes. Next. So, but the limitations with the methyl malonic acid levels are they can be seen, the high levels can be seen in elderly, in renal impairments and hypovolemic states. So, we can have the false positive deficiency status. And similarly, for the homocysteine level, the limitation is again renal impairment and a decreased, the homocysteine levels can be increased in decreased folate and B6 levels as well. Next. So apart from that, we can also have a check on the holotranscobalamin levels. Since the holotranscobalamin or the active B12 form, though it carries 10 to 20% of B12, but it is available for use. So even the TC levels can be done to detect the vitamin B12 deficiency. Next. So it has a better sensitivity and specificity for assessing the B12 status. And because it is not affected by the haptocorrin levels. So, but still, due to the limited availability and the high test cost, it's not used as a first line test of choice. Next. So again, the table here, it's a chart which depicts that in case of the gray zones, that is, in case of people with less than 140 levels, the B12 deficiency is taken into consideration. But for people with levels between 140 to 250, we can go in for holocobalamin measurement. Next. So the treatment include the oral vitamin B12 supplements or injections of cyanocobalamin. And in other things, that is the other causes which can be treated, they have to be treated, like in case of infections or in case of malabsorption syndrome. So they have to be definitely taken care of to increase the vitamin B12 symptoms, deficiency symptoms. Next. So the chart here shows the time to taken for the different abnormalities in case of B12 deficiency to improve. So the neurological symptoms, they take around 6 weeks to 3 months to improve, and the anemia, leukopenia get back to normal by 8 weeks. So the earliest to come to normal is the reticulocyte count, the homocysteine or the MMA levels. So apart from that, for the B12 deficiency, we can have the dietary supplementations, like increase intake of the animal and dairy products and food fortifications. Next. So always the thing to be remembered is that prevention is always better than cure, be it vitamin B, B12 or vitamin D. So the best thing is to have a good diet, have a good sun exposure, and have a good balanced healthy diet. Next. Thank you.
Well, thank you very much, ma'am. That was quite a detailed, and you went really into the deep details with respect to vitamin D and vitamin B12. You did mention in your discussion on B12 that there is no established gold standard right now in terms of testing.
Yeah.
Yeah. So when as a diagnostician, when you are faced with a and patients being what they are today, they say, I got vitamin B12 from that done in one lab. I got vitamin B12 done in another lab with another system, even though they may both be CLIA systems or they may be ELISA or a CLIA system, mix and match. How does the diagnostician come to the, come to the right answer?
Yeah. So one thing is if we have a good testing system at hand, be it ELISA, be it CLIA, that's the first and foremost thing that we require. But yes, the patient symptoms, the clinical signs, they are very important, equally important. So if we have a patient presenting with a macrocytic anemia, and with the typical hemogram picture, or with the symptoms which show anemia as well as neural symptoms. So along with that, even if our testing says that the B12 is borderline, or we are in a doubt, but still we can go in for a B12 therapy for in that cases. So I think it's a combination. It's a combination of the signs and symptoms, what we find in the clinical scenario, as well as what we find in the diagnostic scenario.
Right. And ma'am, these standards which are established, whether it's vitamin D or vitamin B12, the numbers that they say 20 and 20, between this number, you are deficient, you are toxic, whatever. Are these vary, right, across, are these global numbers or they vary from geography to geography? Because I do know
There
for
is
a fact.
always a variation. See, there is always a variation. Mostly the studies, they are done in the countries outside. They set the limits, and definitely we have to make a limit according to the Indian population. So that is why we have some gray areas as well. That till this range, yes, we can consider, like in B12, we have a borderline zone, a gray zone. Similarly, in D deficiency, we have an insufficiency area zone. So yes, so again here what I would say is that the clinical signs and symptoms, they play a very big role. So if a person is having a lot of symptoms and still the testing shows that the B12 or D levels are like borderline, so definitely they have to go in for some kind of treatment or fortification or some kind of other preventive therapies.
Again, one thing that came to mind when you talk about vitamin D, especially vitamin D, is there is there are a lot of, like you talked about osteoporosis. There is
Yeah,
the deficiency of vitamin D is one of the causes of osteoporosis,
a
but
very
it's
big
not
cause.
causative. There is a difference between deficiency and associated disorders and a direct cause, a causative thing. So does this come into play when you look at vitamin D? It not just affects one particular. Uh,
It affects the entire system, right? Starting from your, I think the nervous system, going on to the cardiac system, the GI health, the bone health, the muscle health. So, in even in COVID, we saw that vitamin D has a very big role in your immunity. So vitamin D definitely, it is an interplay of different systems. It's not a whole single deficiency, but yes, it's an interplay of different systems.
because that comes into play when you're actually coming to diagnosis and giving treatment.
Sure. That has.
And I'm sure you have your own laboratory, and you use a certain system for your own testing. Well, not getting into the brands and the name of the testing, I'm sure you are using chemiluminescence, if I'm not wrong.
Yeah. We go in for both depending upon like if matlab, like if a person is not ready to pay for the chemiluminescence, but yes, we still want to get tested, so yes, we can offer in for ELISA as well.
But again, ELISA is again a batch testing. It requires more samples.
It's a batch testing, but still it's okay. It's something is better than nothing. It's still good to have something get tested. And though in certain cases you don't need, the symptoms are so sure, but still these days you cannot go ahead unless you have a lab report in your hand.
And I've seen that most doctors do prescribe a standard vitamin D and a vitamin B12 test for.
Yeah, because these days, see, this is what I was coming on to. The hair problems, the skin problems, cosmetology is not into being.
Right.
So hair and skin problems are one thing that everybody is dealing with. And the first and foremost testing that comes in this category is thyroid, the vitamins, D, B12, and ferritin. So I think that's a very common prescription these days.
So over the last, let me say, a decade, have you seen a radical increase in the kind of awareness at the at the patient level?
Definitely. There is a big increase. Even patients who have not consulted the doctors, they are like coming up and saying, ki, yes, we want to get our D and B12. There's a lot of hair fall. I think I need to get my D and B12 levels. The COVID has definitely prepped up their knowledge, and they have come up with this idea ki, yes, vitamin D is affecting all of their systems.
Okay. Now coming to the questions that have come from our audience, I will ask you to indulge us a little more because our audience has been active and they have come up with quite a few questions. Um,
And
so
let's see how many I can answer.
I'm sure, ma'am, with your expertise, they shouldn't be too difficult because I think these are real world problems in terms of what they're facing. So the question came. Sometimes the laboratory technologists are asking for the direct correlation between the red cell indices, especially MCV.
Yeah.
Is there any direct correlation between vitamin B12 and MCV, or it's a myth that less vitamin B12 will always lead to higher MCV?
Usually, it's a usual finding. That's the first finding. Usually, whenever see MCV is a mean corpuscular volume. So whenever there is a B12 deficiency and we have a macrocytic anemia presenting with that, the MCV usually tends to be on the higher side, and it has a definite correlation.
But how does it help in terms of the older patients when they notice, when who go in for vitamin B12 therapy and their B12 level obviously increases, but their MCV also goes up to a higher side. So how does
No. Usually, once you start with the therapy, so once the retic count start coming to the normal, with time, even the MCV comes to the normal.
okay? So it,
MCV, once you're into the therapy, most of the times what we used to read was ki once you get the B12 injections, so within days, the hemological signs and symptoms they go off. The bone marrow responds very early. The retic count goes off very early. So MCV does not remain that high.
I'm coming back to vitamin D for a minute. There are ELISA and specifically ELISA. There is the competitive delayed competitive method of ELISA, and of course there is the sandwich method. Which one has more correlation in your understanding with the actual true estimation of vitamin D?
See, I really didn't go into that much depth about the methods, but yes, what the one thing that I found was in ELISA, in total in the ELISA procedure, since as we know that that the vitamin D is bound to D binding protein.
Correct.
So in that ELISA procedure, that washing has a very important role. Unless you separate that D from the D binding protein, you cannot get the actual level of vitamin D.
Yeah, that
So
is what I
that's
think. Vitamin D has always been a little tough thing to
yeah.
crack. It's got a shell
Huh,
around
huh.
it.
And with the ELISA procedure, that's even a tougher call. Most of the times, like even if I am going in for ELISA procedure, once the value comes, if it's very low, I'm also in a fixed key whether is it this low or is it a bit higher than this.
All right. Uh, in our chat screen also we have a couple of questions. Um, well, of course, one person asked a simple question of how can one increase vitamin B12? That of course.
Vitamin B12, if you are a vegetarian, it's a tough call. But if you're a non-vegetarian, then eggs, meats, poultry, that will help you a lot.
I do believe the person.
Vegetarian sources are comparatively less. Can go in for dairy products, soya beans, legumes, they'll help you.
Oh, that's great. And how do you differentiate between active vitamin D in diagnosis from 25-OH vitamin D? Is there a
Uh,
difference? One of the questions has come from our
the calcitriol
yes, I
from
believe that.
the
He said the question is how do you differentiate between active vitamin D in diagnosis from 25-OH vitamin D? As in, how does 25-OH vitamin differ from 1, 25-OH?
the liver from the kidney form.
Yes.
Mostly in circulation, or mostly you will find the kidney form. The liver form goes once the vitamin D is being manufactured, it's been converted. So from the liver it comes to the kidney, and what we find in the circulation is the calcitriol form. That's the active form.
Okay.
So I really don't find the other form being a challenge in the diagnosis.
Again, there was another question that I think it's a repeat of what I asked you earlier. Ma'am, as a pathologist, how do you correlate the variations of vitamin B12 results across different instruments like Beckman, Roche, Abbott, Siemens, and a whole lot of other brands on a daily? Because on a daily basis, we encounter variations with beyond 20% CV in these instruments.
There are variations. See, definitely if we take procedures into account, be it ELISA, going on, then prepping up to RIA or FIA, or then going on to CLEAR. So ELISA versus CLEAR is a big difference. Yes, there is a difference, and there is a doubt, particularly in the borderline areas, whether you have to give it as a normal or you have to remain in the borderline, right? But then if we talk about different instruments, I don't think so they would put in so much variation. If it's a CLEAR with Beckman or a CLEAR with Roche, that won't put in that much difference, because the cutoff values of the different instruments or the different testing kits might be different. But
Absolutely.
I don't find so much difference in the values.
Because in the end, they're all immunoassay reactions.
Yes, all of them are good companies, all of them are good reagents. So I don't feel that there is a big difference. Like one of the machine will place the patient into a normal category, and other would take him to the borderline or a below level category.
And
No,
what
that would
actually observed is that when you're clearly on the lower side or clearly on the higher side, there is never any doubt. The
there's no
challenge,
difference. So the
the
major
challenge
difference
always
is the
comes with the gray
borderline.
zone. Yeah, the
And I
borderline.
think in those cases, none of the things is going to help. You have to correlate clinical findings along with your lab findings.
I'm wondering who asked that question. It's a very interesting one because that actually comes, I think, comes from somebody who's in the diagnostic line and who's facing this
Definitely,
question at the
definitely.
lab end.
As a pathologist, I would definitely say yes. ELISA versus CLIA is always a doubtful. CLIA may, once we receive a value, we are like, yeah, CLIA says that, so it's okay. ELISA may, we are always doubtful whether it is actually in the gray zone or it's in the lower normal zone.
But going forward, I think as you look at development of these tests,
And then again, it depends upon how your technician is, how well your technician is trained for the ELISA and how well he is performing.
of course, nobody doubts the fact that uh, comp you know the competence
Competence of your technical staff.
very important for ELISA. And I
Very,
think
very
Clea has
important.
changed that, right? Clea has equalized it because it's all fully automated.
Clea has changed that.
So yes,
It's fully automated. So
we
that
can-
is what I'm saying. Ki ELISA is more technical based. If you have a very good qualified technician who is really precise in his methodology and takes care of each and every step, so then you are definitely sure, yes, you can confidently report your borderline zone. But if you are like still a bit dicey that he might have committed this error at this step, so then you are in a mess.
you're looking at 4 washing steps and multiple
Yeah.
and one little problem in the dispenser and you're
And then you are in a confusion.
I understand. But I think the future for vitamin D and vitamin B12 is, I mean, the amount of testing that's happening and the more research that's being done into their, the kind of diseases you're getting, they're associated with almost every part of your human body.
They are, definitely they are.
Well, thank you, ma'am. Thank you so much for your time. It's been wonderful having you over with us again. And
Thank
we
you.
look
Thanks a
forward to
lot.
the future.
Yeah, sure, definitely.
Our manager, Mr. Avinash or Mr. Mukesh, will be in touch with you. We'll
Yeah,
actually have
sure.
a hard copy of the certificate sent to you directly, right?
Thank you.
Thank you again, ma'am, for the hug. Thank you very much.
Thanks a lot.
Thank you, ma'am. Thank you very much.
Thank you.